Hi, everyone. My name is Kavita Dharmarajan. I'm on the faculty at Mount Sinai Hospital in the Department of Radiation Oncology, and I will be talking with you about the concept of palliative radiation therapy. This is going to be an overview for evidence-based management for oncologic diseases. I have no disclosures. My lecture is designed for folks who are not familiar with radiation therapy and the various palliative treatments that it can provide. It's intended for you, palliative care and geriatrics and primary care physicians. I'll discuss the basic principles of radiation therapy, describe indications for palliative radiation oncology treatments. I'll recognize some of the side effects from radiation treatment, and I'll discuss the burdens and benefits of the radiation treatment for patients. Most cancer patients will require radiation therapy at some point during the course of their illness, and about 30 to 40% of all radiation treatments are actually palliative in nature, which means that they're not meant to cure the condition, but they are meant to ameliorate symptoms, to prevent symptoms, or to in some way improve quality of life, or in some way to improve the chance of continuing on with the condition of an incurable cancer with the best quality of life that's possible, and for the longest time that's possible. We'll start with a case of cough. This is the first case that I'll present to you, which will describe how we sort of think about the use of radiation therapy in the context of a cancer patient. And this treatment that I will describe is actually not considered palliative. It's considered part of a curative treatment, but it will give you a sense of what, when we talk about the later cases that are palliative, how we think about radiation therapy in general. So this patient, Mr. Xavier, is a highly functioning 56-year-old gentleman with a smoking history who presented with cough and weight loss for about 6 months to his primary care provider. Workup showed that he had a large right high mass with bulky mediastinal lymphadenopathy, and a biopsy was done that revealed small cell lung cancer. So pathologists described this stage of his disease as small cell lung cancer that is of a limited stage. Limited stage means that he is potentially curable with treatment. So he's going to be meeting with his oncologist who's going to plan out his treatment. So what do we think the oncologist may offer Mr. Xavier? The answer is that they will offer chemotherapy with concurrent radiation therapy, and that is going to be the curative form of treatment for this gentleman. Backing up a moment back to high school physics or biology, what is the critical cell target for radiation therapy? It's the DNA. Radiation therapy causes double-strand breaks in the DNA, and when the DNA has double-strand breaks, then the cell is informed that it needs to either repair, or if it can't repair, then it dies. And when the cell dies, the cancer cell dies, then that is the kind of outcome that we want to achieve from any radiation or chemotherapy is cell death, cancer cell death. The critical cell target is the nuclear DNA. So the double-stranded breaks in the DNA appear to be the lesion that's responsible for cell death. Cells that are rapidly dividing with high oxygen levels are more susceptible to radiation, and they're more susceptible to X-rays and gamma rays. So there are two pathways. There's the direct pathway that X-ray can damage the nuclear DNA and cause the strands to break, and then the cells will die. The additional indirect pathway of cell death happens when an X-ray kicks an electron out of its spin, and then that electron causes a free radical formation. A free radical then is highly reactive and damages the DNA strand by that pathway, and then that's another pathway that the cell can die. So there are two pathways, one is direct and one is indirect, that radiation therapy works to cause cell death. Radiation therapy can be delivered with a few different types of particles or waves. Electrons, which is best for superficial treatments. Photons, which is the workhorse of the modern day radiation machine and what we typically use in radiation oncology clinics every day. Protons, which are highly specialized, highly conformal, not widely available, lots of guardrails around their utilization, and very expensive. And then neutrons, which are heavy particles, neutral charge particles, not commonly used in the US, but they are used worldwide. And so they are one of the things that I just wanted to mention if you hear that term. We typically will just decide which particle we want to utilize in a particular type of treatment based on what sort of dosimetric properties that we want to exploit from it. So, for instance, electrons help us if we want to treat a person's skin. If there's a skin cancer or if there's a tumor that's involving the skin and we don't really want to get dose lower than the skin, then we will treat with electrons. Photons penetrate deeply. They come in a variety of different energy levels depending on how deep we want the penetration to be. And then protons go all the way through. Protons will actually stop at the place where we just prescribe them to stop. So that's one way in which they are very highly conformal. There are 3 different types of radiation treatment, or 3 different sort of ways of terminology of the different ways that radiation can be delivered. One is definitive radiotherapy, which is the intent to cure. For that example of that is a limited stage small cell lung cancer, which is Mr. Xavier's case, lung cancer. There's adjuvant radiation therapy, which is the radiation that happens immediately following a surgery or within a few weeks of a surgery as part of the curative intent treatment. And the example for that is breast cancer. Person may get a lumpectomy followed by, radiation therapy to the whole or partial breast, and those 2 treatments together constitute the curative form of treatment, and that's after a surgery. And then there's palliative radiation therapy, which is what we'll spend most of the time talking about today, where the intent is to alleviate symptom burden. And then just side note, energy, the radiation therapy is delivered in an energy. The energy is measured in gray. So we'll often talk about how many gray we're going to be giving a patient who has breast cancer, for instance, or how many gray a head and neck cancer patient will get with their radiation therapy. And 1 gray is equivalent to 1 joule per kilogram. There are 3 ways of delivering radiation therapy. There's teletherapy, which is when external beams of radiation are generated at some distance away from the patient and then aimed at the tumor within the patient and delivered by an external beam machine. That's the most widely used form of radiation therapy. There's also brachytherapy, which is when encapsulated sources of radiation are implanted directly into a tissue. The best example of this is that in the treatment of prostate cancer, many patients who have localized prostate cancer of a certain early stage may have little radioactive iodine seeds that are placed inside the prostate gland during a surgical procedure or urological procedure. And then those seeds will distribute radiation throughout the prostate gland and kill the cancer cells in the prostate gland. And then there's systemic therapy, which is where radionuclides are delivered either intravenously or by mouth, and there's more systemic absorption of the radiotherapy. The best example of this is in the treatment of prostate cancer when patients are receiving radioactive iodine. There are 2 instruments used to deliver external beam radiation. There's the linear accelerator, which is the machine that is used to deliver external beam radiation in most clinics around the country. And then there is a cobalt machine, which is where the radiation is delivered with an actual source of the element cobalt that's kept behind in a shielded manner. And then when the radiation therapy is needed, then the doors of where the cobalt source is held is open and the radiation is emanated, which is constantly emanating from the source, is emanated. But this is a more antiquated way of delivering radiation therapy. We don't really use cobalt machines in the US anymore, but we do sometimes see them more internationally. So this is what a radiation therapy machine looks like. This is a linear accelerator. It hangs on it's attached to a wall, and then it rotates around And then this is where the patient will lie down. And then the machine, or the head of the machine, it's called a gantry, will rotate around the patient. And you can see that these yellow rays of light is sort of delineating where the radiation rays would come from. So when we're thinking about treatment planning with a radiation oncologist and a palliative setting, we first wonder whether treatment will be worthwhile doing, and then how treatment will be accomplished, and then if there are other necessary players that we need to include in the planning or the discussion of radiation treatment or any type of palliative treatment, who those decision makers are going to be. When we're thinking about whether treatment is worthwhile, we think about whether, how long do we think that a patient may have to live? Are they able to give their consent, or do they need a proxy? Will their treatment delay downstream medical treatments or therapies, including if there's a hospice referral that may be getting considered? Will the radiation treatment delay that, because many hospices won't take patients who still need to have radiation, since radiation can be pretty expensive for hospices to reimburse or to pay for. Will the patient live to suffer the side effects of the treatment, but not experience the benefits? And then, are there symptom clusters that may negate the potential benefits of the radiation treatment? And if that's the case, then are there other treatment modalities that could offer equivalent symptomatic relief? Once we decide that treatment will be delivered, that it is worthwhile, we think about where exactly in the body we want to treat, how much volume of tissue do we want to treat, what dose do we want to give, etc. So in terms of simulation, which is the first step of radiation treatment planning, we bring the patient in to immobilize them. We do a CAT scan, and then we place an isocenter and then mark them with tiny tattoo marks. Sometimes we will make something called a face mask that looks kind of like this if we are treating the head and neck region. And these are things that we use to help the patient stay in a still kind of same position every day, so we can make sure that we're delivering the radiation treatment to the areas that we think that we are. So back to Mr. Xavier's plan. What did we do for him? So in terms of the chemotherapy, he was prescribed by his medical oncologist two drugs that were given at the same time, cisplatin and etoposide, and the radiation was given twice daily over 3 weeks, or sometimes we do it if they can't come. Patients may not be able to come twice a day for 3 weeks. Then we would give a slightly higher dose of once daily radiation for 6 weeks. So we gave 45 gray as the prescription, ideal prescription, or 60 gray once daily. So we advised him in terms of side effects that he may have skin changes, pulmonary fibrosis, generalized fatigue. There could be a chance of developing pericarditis. We did not say that he could have somnolent syndrome. That's a side effect from whole brain radiation therapy. So that was one of the side effects that we did not expect from his treatment. To talking more about side effects and what we can expect and why, there is some logic in terms of radiation treatment side effects. We can't blame everything on radiation, contrary to sometimes what some people think. Since radiation can't be seen or really felt, or it's a little bit abstract, sometimes we'll think that some things may be caused by radiation treatment, but they're really not something that we would expect. So how do we think about what to expect from radiation? Well, we look at the location of where the treatment is being delivered anatomically in the body, and the dose, the duration of the treatment, what type of radiation treatment was given, whether it was neutrons or photons or electrons. Neutrons tend to be more damaging because they're heavier particles. Whether treatment was given with chemo concurrently, the age of the patient, other comorbidities, if there are any autoimmune or inflammatory diseases, these can predispose patients to developing sort of exacerbated side effects. And then when they occurred in relation to the radiation, we consider acute reactions to occur either with treatment or immediately after, and then late reactions we think of as taking place or being apparent 3 months after treatment. Anything that happens within about a month and 3 months is considered to be sort of subacute reaction to radiation treatment. So when we think about the location of the treatment, if someone's, oftentimes radiation will go through, well, every radiation X-ray has to enter the body via the skin. So depending upon how close to the skin the actual treatment target was, a person may develop some skin toxicities, and these include erythema, dryness, so sometimes desquamation. Late reactions can include fibrosis or atrophy or telangiectasias. This can happen commonly. Both of these types of things can happen commonly with long courses of breast radiation, for instance. If someone's getting radiation to, the pancreas or a liver or some, very internal organ, they may not have as much as the skin toxicity may not be as relevant for them, but they still may develop a little bit of redness on their skin surface that will go away within a couple of weeks. For brain, we see lethargy or cerebral edema as an acute toxicity. Lethargy is very common. Cerebral edema is less common. We oftentimes use steroids to help mitigate both of those toxicities. And then late toxicities will include somnolence syndrome, or sometimes even brain necrosis with very high doses of radiation. Mucosa is very commonly affected because it's a type of mucosa made of skin cells that are rapidly repopulating. So patients can develop erythema or edema or mucositis. And then lung toxicity can be fibrosis or pneumonitis between 6 weeks to 6 months. And if someone develops pneumonitis, that they're more likely to develop pulmonary fibrosis as a result of that. Heart toxicities include pericarditis or effusions. Long-term toxicities are cardiomyopathy, but we try to really avoid this by not radiating the heart or making sure that very, very small, volumes of the heart tissue are in the radiation field, since that's a particularly damaging toxicity. GI toxicities include mucositis, since there's mucosa all along the GI tract, and then late toxicities include ulceration or fibrosis that may lead to strictures, malabsorption, or fistulas. In the kidney and bladder region or GU region, we may see dysuria or urinary frequency, sometimes some urinary retention. Late toxicities include hematuria or ulceration of the bladder, proteinuria, which can result in renal failure. In bone marrow, we'll see thrombocytopenias, neutropenia, or later pancytopenia. So just wanted to mention a little bit more about radiation pneumonitis. Radiation pneumonitis has a look on an X-ray that can resemble a pneumonia. The tip is that it looks like alveolar and nodular infiltrates with air bronchograms that correspond to like a wedge pattern or a pattern that's more geometric, and that's indicative of a radiation treatment field. It can present like a pneumonia would present with fevers and shortness of breath, but it needs to be treated with steroids as the mainstay of the treatment, along with sometimes aspirin, cough suppression, bed rest, and sometimes there can be a superimposed pneumonia as well, so empiric antibiotics. Every organ in the body has a different tolerance range for what it can tolerate before developing a long-term injury. And each organ has a very different, number of gray that it can take. So for instance, brain can tolerate quite a lot of radiation before, late toxicity develops, whereas testes and ovary can tolerate only very, very small amounts of radiation before a person may get sterilized from the radiation. Basic management for side effects is, symptom management. And it's very common sense. So for instance, in the skin, you want to counsel the patients to avoid any extra chemicals on the skin, aluminum deodorants, aftershave lotions, or astringent cosmetics. Prefer, to use mild soaps instead and gently wash over the sites so as not to disrupt the skin that might be very fragile. We use aqueous creams for mild reactions. hydrocortisone over the counter for itching, and we use hydrogel and Zeroform dressings for very severe reactions. And we try really, really hard not to have these patients develop superimposed infections over the skin. And that can be particularly challenging if the skin is in, intriginous areas or areas where there's also a lot of sweating that's happening, or sometimes behind the neck in someone who's mostly bedbound. Mouth and throat care should be done aggressively prior to radiation, because we don't want anybody getting any extractions, or, fillings are fine, but really like no extractions should be done right after any head and neck radiation for a period of time, like 6 months sometimes, or sometimes even a year. And we try to counsel patients to stop smoking, stop using alcohol, or eating a lot of really spicy foods, because these can be triggers for or exacerbating factors for side effects. And then we want to counsel patients that mucositis can be treated with mouthwashes or analgesics. Nausea and vomiting, serotonin antagonists work the best, but also steroids, and also sometimes benzodiazepines like Ativan. For diarrhea, we counsel patients to use loperamide or rectal steroids if there's proctitis that's found. And for pneumonitis, steroids typically begin with prednisone to 40 milligrams daily, and then that gets tapered up or down based on the symptoms. For somnolent syndrome, which can manifest as nausea, vomiting, anorexia, ataxia, and lethargy, we can anticipate that recovery may be accelerated with steroids, but it can sometimes last for several months, especially after whole brain radiation. And all of these, steroids is one of the mainstays of treatment that we use in radiation oncology for symptomatic management. So to conclude Mr. Xavier's case, he was successfully treated and returned to his usual life without many side effects from his treatments. Let's move on to a case that is truly palliative in nature. And this is a patient with a history of a 62-year-old woman with a history of HER2-positive breast cancer, who had definitive treatment of her illness, but then presented to oncology with very severe hip pain that she described as sharp and aching and keeping her up at night, despite taking 2 tabs of Percocet every 4 hours. Her performance status was 70%, and a plain film of her hip showed this large destructive lesion in the iliac bone of her right hip, just above her right hip, actually, with extension outside of the bone. So this was extra osseous extension outside of this bone, which is a weight bearing kind of a structure here. So how would we think about giving her radiation therapy? There are several different ways of giving palliative radiation therapy to the bone. We can use 8 gray times 1, which is a very low dose of radiation that's supposed to give symptomatic relief within a few weeks. We could use 3 gray times 10 doses, or basically 2 weeks of radiation. That is oftentimes used in areas of the bone where there's weight bearing or there's extra osseous bone involvement, where we need a little bit more durable local control. There's radioisotopes that are given when patients have many diffuse bone mets, and then there's the option to do steroids and physical therapy alone. And what should we do for her? So for her, it's really going to be only one option, which is external beam radiation therapy with longer than just 1 dose of radiation. We could do 3 gray times 10. It's not here on the slide, but I'll just say it. We could also do 5 doses of radiation at 4 gray times 5, so that's 20 gray. Both of these would be acceptable for her, but the 8 gray times 10, the radioisotopes and steroids and physical therapy alone are not really acceptable options for her. But I mentioned that the 8 gray times 1 may have been, if she didn't have this extra osseous extension, or if it wasn't in this weight bearing area or so large, because it's not really going to give us control over the tumor, it's going to maybe palliate pain, but we want her to have some control over the tumor and to shrink the tumor, which needs more doses of radiation. So in her case, more is better and to a certain degree. Talking more about bone mets. Bone mets are common manifestations of distant relapse for many types of solid cancers: lung, breast, prostate. 80% of patients with solid cancers develop painful bone mets to spine, pelvis, and extremities. And radiation therapy for bone mets can be divided into 2 types: external beam radiation, which I talked about in her case, as well as radiopharmaceuticals, which are bone targeting radioisotopes that are more appropriate when there's a significant number of, diffuse bony mets that you think are causing pain. You can't really isolate the pain to one area, or you're wanting to control the bone disease. And one, popular example of the radiopharmaceutical, besides the strontium or samarium, strontium I talked about on the last slide, which is a very old radioisotope that's still, it's an oldie, but it's a goodie. Samarium is the same, but more recently we've been using radium-223, or a radium isotope, which is also known as Xofigo, and it's one of the most commonly used ones in prostate cancer bone mets. External beam radiation therapy, or EBRT as it's written on this slide, is very effective. It can provide pain relief in 80 to 90% of cases, and it can provide complete response to pain in actually about half, or maybe even a little more than half, of the patients who receive the radiation. So it's definitely a very, very useful tool that we use in radiation oncology to help people with cancer pain that's from bone mets. The most commonly used regimen in the US is 30 gray and 10 fractions, because we have the most experience with it, but we have a lot of clinical trials that have demonstrated that 8 gray times 1 is just as effective in terms of pain control up to 3 months after treatment. It just may not be as durable, after that, and it may not control the tumor if you want tumor control. So it's best used in cases where there is no extraosseous disease, or there's not a concern that if you don't control the tumor that a person might develop a fracture, or, vertebral body or spinal cord impingement. Importantly, that during therapy, some patients may experience a transient worsening of pain. We call that a pain flare that comes because there's tumor cell death that's happening, and then there's some edema that happens as a result of cells dying, which can last for a few days and is highly amenable to being treated with steroids. So sometimes we just use steroids prophylactically to prevent the discomfort that can happen as a result of the pain flare. When do we use pharmaceuticals? Well, radiopharmaceuticals rather. I mentioned in the presence of widely metastatic bony disease, widespread and diffuse bone marrow or bone disease. And I mentioned the three medications that we typically use. They're likely equal in efficacy than in terms of pain relief to external beam radiation, and they're safer to use when you have lots of areas of the body that need to be treated, versus just as 2 or 3 areas or one area that you can target with external beam radiation. Just one word of caution with radioisotopes is that since they are, internally, they're systemically metabolized, they can be also excreted in toilets, and sometimes that can be an issue if patients have other family members that may be living at home. So for about a week after the injection, patients are typically advised to use a normal toilet instead of a urinal, and to flush the toilet twice after each use, wash hands with soap and water, wipe up any spilled urine or blood, immediately wash any stained clothing or bed linen separately from any laundry, and they're not recommended if someone's pregnant because of the risk of malformations and genetic disease, teratogenic effects. So back to the case. So she received Miss Anne Marie, who's our patient that we're discussing in this case with the breast cancer and the metastatic disease in the right hip, received a chemotherapy and external beam radiation to her hip, and her symptoms improved, and she was able to travel to Florida. She regained a lot of her function, and had reduced pain in her hip, and was able to ambulate freely. However, when she was in Florida, she presented to a Florida hospital with persistent headaches, nausea, and vomiting, and an MRI of her head revealed that she had new brain metastases. So now how are we going to deal with these brain metastases? Well, let's first think about it sort of more generally, which is that what would her prognosis look like if she did not get treated for these multiple brain metastases? She would likely have a prognosis of about 4 to 6 weeks. This is without any treatment at all. So in terms of brain metastases management, we kind of think about survival without treatments about a month or two. With steroids, you can increase the survival to about 2 to 3 months. With whole brain radiation therapy, survival can increase to about 6 to 10 months. This is, in sort of more historically, we think about these survivals. Now, with the advent of more advanced therapeutics, chemotherapy, immunotherapy, we are looking at survivals that can range after, for years after whole brain radiation therapy. So we think about, but still we think about prognosis as being much more favorable for patients who are starting out with a good functional status, because the side effects of whole brain radiation therapy can be pretty severe in patients who are already somewhat debilitated. They may not be able to then, even though they may finish whole brain radiation, they may not be able to go back onto their chemo. And then if they're not able to go back onto their systemic treatment, then they're not going to really see the benefits of the radiation treatment. So the performance, even despite the advent of new advanced therapeutics and immunotherapy and all the rest, still we think about patients as, their prognosis is being heavily affected by their initial functional status, as well as their age and how much other disease that they may have. About the most common tumors to have brain metastases are lung, breast, melanoma, renal cell, less colorectal cancer, less GU cancers, GI cancers less typically go to the brain. Hematogenous spread is most common and is the most common mechanism, and they're usually to watershed areas. So 80% of brain mets are found in the cerebral hemisphere, 15% in the cerebellum, and 5% in the brainstem. But that's pretty, proportionate to the amount of real estate that each of these areas takes up in the brain. Most of the brain is the cerebral hemisphere. About 15 to 20% is the cerebellum, and about 5% of the, space is taken up by the brainstem. So it's pretty proportionate. Brain mets can present as headaches, nausea, vomiting, new seizures, cognitive changes, new focal deficits, or stroke. And then I won't discuss too much about this chart, but this is basically a recursive partitioning analysis that helps to describe how to put patients into the different classes based upon their based upon the KPS, age, brain, location of the metastases that they may have, and then the output is the median survival. And you can categorize patients into 3 classes based upon these different parameters. The patients who do the best are the ones who have a KPS of equal or greater to 70%, who are younger than 65, controlled primary site, and no extracranial mets. And here it says their survival is 7 months, but this paper was written now 25 years ago. So I think this is pretty much kind of outdated, but in terms of the median survival number, I would put that at over a year at this point. But generally the same principles hold in terms of the parameters that dictate the survival. For patients with better performance status and who may have a fewer number of brain mets, we can use another kind of treatment that is less, associated with the side effects of lethargy and somnolence syndrome, and that is called radiosurgery or stereotactic radiosurgery. It's effective for small metastases or for regions that have been surgically removed, up to about, I would say, probably about 10 or sometimes even a few more brain mets than that. Depends on the volume of the brain tissue that's actually going to get radiated. And if patients have more brain mets than that, we typically will resort to whole brain radiation therapy. For patients with limited performance status, we can use whole brain radiation therapy as a very palliative measure. We can often use even 5 fractions of whole brain radiation therapy instead of 10, which is the typical and more historically the most utilized, at least in this country. Overall response to brain radiation is very good. It's not as good as it is for bone, but it is still pretty high, 50 to 80% or so. We don't want to give brain metastasis radiation, whole brain radiation, when a patient's prognosis is very poor. They have, progressive external to the brain, extracranial disease, that they don't have very many chemotherapy options and such. And that we do have a couple of papers that show that there is really no difference in survival between patients who had whole brain radiation therapy versus patients who had steroids and best supportive care alone, at least in the setting of lung cancer, of non-small cell lung cancer, who had progressive lung disease. Well, let's move on to our next case. We have a patient that we'll discuss who's a 70-year-old gentleman with prostate cancer who had chemotherapy and now presents with 1 week of lower back pain and 1 day of a lower extremity weakness. Functional status is good. Prognosis is better than 5 months, according to his doctors. So on exam, he does not have any subluxation or translation of joint bilateral facet destruction or neurologic changes during his range of motion. His ECOG performance status is 2, which corresponds to a Karnofsky performance status of about 70, and his MRI is as follows. So you can see here where the arrow is pointing that he has a significant anatomic pathologic collapse and retropulsion and abnormality and metastasis at the second vertebral body of his thoracic spine, or T2. So what is the next step in his management? Is it immediate surgery, immediate radiation, immediate steroids, or with referral to radiation, or immediate steroids with referral to surgery? He's also looks like he's got tenting of his spinal cord there. So this is a spinal cord compression that's a result of this piece of bone that's retropulsed back into the spinal canal. We can't fix that with radiation, so he needs to get steroids to reduce the edema that's probably resulting in his cord, causing his neurologic symptoms, and referral to neurosurgery. So this is malignant spinal cord compression. It has an incidence of about 3% in cancer patients. Most common condition is multiple myeloma. Happens about 60% of the time in the thoracic spine, 30% of the time in the lumbosacral spine, and 10% of the time in the cervical spine. And pain is the most common presenting symptom, followed by weakness, sensory changes, bladder and bowel dysfunction, and ataxia. First line treatment is steroids, which you can do immediately. The next line is to consult neurosurgery, and they will help you determine whether the spine is stable or unstable. And if it's unstable, based on the fact that whether there is a deformity, bilateral facet destruction, subluxation, or translation of the joint, then the patient really needs to have surgery. Oftentimes, the surgery is followed by mopping up of any residual disease with external beam radiation or high-dose radiation, so it's called stereotactic radiosurgery or fractionated stereotactic radiation. If the patient can, if they're stable without an unstable characteristics, then they may be able to receive radiation therapy alone, surgery with radiation, or potentially SRS alone. Surgery is beneficial for patients with a good functional status, a survival of at least 3 months or more, paraplegia no more than 48 hours, and limited spinal segments that may be affected. Prior to the use of radical surgery, however, radiation was the main choice of treatment, and about 70% of patients had improvement in pain using external beam radiation, although improvement in neurologic status is more variable. We have data that shows that external beam radiation can be delivered in 8 gray times 1 if patients have short life expectancy, and we're really just hoping to control their pain and maybe just save whatever neurologic function that they have, but we may not be able to regain neurologic function, or we could use like a longer course of treatment, 4 gray times 5 or 3 gray times 10, if we're trying to control the tumor and help it to regress back from the spinal cord. Well, we can use stereotactic radiation for tumors that may be less radiosensitive, and we can treat recurrences with radiation or radiosurgery. But typically, stereotactic radiation is not used in the emergent setting because it takes a long time to start that to plan for that and to deliver that treatment, we would use external beam radiation in a much more palliative or simpler setting, or simpler conventional methods that we can start immediately if the patient is not going to receive neurosurgery. So the bottom line is that external beam radiation is appropriate definitive therapy for patients who are not surgical candidates and have a radiosensitive tumor type. And then it can also follow surgical, and radiation can also follow surgical decompression as well. So the radiotherapy plan for Mr. Summer looked like this, where you can see that everything within this green rectangle and then the yellow sort of geometric shape that's within the green rectangle. This is the area that was getting the full dose. These are the two beams that were coming in, one anterior posterior, one posterior anterior, and treating this T2 area of the spine. Just want to mention the SCORAD randomized clinical trial, which was comparing the effect of single fraction versus 5-fraction radiotherapy for ambulatory patients with spinal cord compression. This was a really landmark study that was published in 2019 that looked at patients about 8 weeks after the treatment, after malignant spinal cord compression, and found that the single fraction radiation treatment regimen was not did not meet the criteria for non-inferiority compared with multifraction radiation for ambulatory response at 8 weeks, but it should be given consideration to the extent where it may have, to which the lower bound of the confidence interval overlapped with the non-inferiority margin, which means that basically for patients who are really debilitated and where we still want to try to treat the spinal cord compression, that it's a applicable type of treatment to use. The patients who, so how does radiation therapy and surgery play together for patients with cord compression? Well, there was a study some years before the one that I just mentioned that looked at that, where surgery and radiation was used versus radiation alone, and found that when you add surgery to radiation, that patients are able to retain their ambulatory ability a little bit better than if you just give them radiation therapy alone. In terms of end-of-life care and radiation treatment, before making the decision to do radiation, it's important to note the balance between the anticipated functional and symptomatic benefits versus the time spent receiving treatments and acute toxicities, and then what hospice benefits may cover. They may cover radiation. It's hospice to hospice specific, but if there are symptoms of pain, bleeding, or neurological catastrophe, and if the patient's expected to live long enough to experience the benefit, which is typically greater than 4 weeks, or if the benefits outweigh the logistical burdens. So it's definitely worth considering if the hospice benefit will cover radiation if you have a patient with a cancer and a symptom from the cancer that could potentially be addressed with radiation. Summary of palliative radiation indications. So external beam radiation achieves pain relief in approximately 75% of bone metastases cases. Radionuclide therapy is helpful in patients with multiple sites of painful bone metastases. Whole brain radiation alone can improve survival, can relieve symptoms, and prolong survival in patients with good performance status and longer prognosis. External beam radiation is the primary definitive treatment for epidural metastases with or without spinal cord compression with steroids, and then surgery is for those patients who have bone instability or longer prognosis. And palliative radiation can be given for pain control, neurologic compromise, obstruction, and bleeding tumors. And hospice can sometimes cover palliative radiation if they are engaged early. So that's all for my talk. Thank you so much for listening all the way through. I'm happy to take questions over email. Please feel free to reach out, and it's been a pleasure to record this for you. I hope that you enjoyed it.